So, David, have you ever thought about what surgery was like before we developed all this imaging and scanning technology?
Honestly, I have. It's kind of amazing. We're so used to all of this technology and all of this knowledge that doctors have now, but it wasn't that long ago when they were just kind of hacking you open and hoping for the best.
Not at all. And of course, they understood human anatomy, but not your specific anatomy. And they'd have descriptions from patients about where the pain was, but still.
Really just kind of crossing their fingers and trusting the process, I feel like.
By the way, this is Smarter Than Cancer, and I'm Hajar Aldas.
And I'm David Hoffman.
And so, David, eventually came the x-ray, right? And that gave doctors a real first look of what's inside your body, but mostly bones at that point. And then many, many decades later, we got the CT scan, which revealed soft tissue. And then the MRI came along, which gave even a more detailed image of what's going on the inside, and it showed things like muscles and organs and vessels. And with each new tool, doctors got a clearer and clearer picture of what was going on the inside. But now we've hit this new level where they can take all that scan data and turn it into a 3D model of your actual personalized anatomy, something that they can study and rotate and even 3D print.
Wow. I'm almost picturing like Iron Man at his workbench with those like 3D holograms of the thing he's trying to build, and he's just like waving his hands and rotate. I mean, is this the kind of thing we're talking about?
Kind of. My mind was blown. I spoke to Dr. Larson Hsu, and he's the director of 3D imaging here at Roswell Park. And he walked me through how they're working on developing a process where they take your CT or your MRI scan and they turn them into this super detailed 3D model that your surgical team can hold before they go into the operating room. It's like giving your surgeon a tech rehearsal before they go in and do the real thing.
They can actually touch it. It's an actual physical
They can
sculpture.
hold it in their hand.
Wow. This is amazing.
It's really exciting, and Dr. Hsu kind of imagines with me what the future would look like in 10 years. It's really fascinating stuff.
That sounds amazing. Let's let the CAT scan out of the bag, shall we?
Let's do it. I've gotten many medical scans in my life, both MRIs and CT scans. And every time I go into one of those medical imaging centers, I come out with a CD that I'm asked to give to my doctor. And so I do, but I've always wondered, what is actually on those CDs? I mean, I know it's an image of my anatomy or a part of my anatomy, but when the doctor opens up that CD, what are they actually looking at?
Traditionally, medical imaging, by using CT or MRI, we create a series of cross-section images. Our clinicians, our surgeons, our diagnostic radiologists are looking through a series of just basically slice by slice of your body. But as you know, the normal people don't perceive the world as in cross-sections. When you look at something on the table, you're not imagining or interacting in a way that's cross-sectional. So by giving our surgeons cross-section images, they have to reconstruct it in the head to sort of almost guess, where the tumor is in relationship to the vasculature in a 3D world. And that's not how people operate, right?
So wait, you're saying that using these traditional imaging tools, the doctor is basically seeing just a series of flat images?
Radiology programs or radiology departments across the hospital, they do have a 3D lab, basically we can take a CT or MRI cross-sectional images, and then you can transform into some sort of a volume rendering as in a 3D image. But it's usually a very simplistic way of depicting something in 3D, because just think about it. Our whole body is filled with different things. There's fat, there's musculature, then there's vasculature, as in blood vessels, and there's also different organs. So it's like looking at the forest, and then all you're going to see is trees. So it's hard to see what's actually inside the forest. If you want to see an apple in the forest, you actually have to isolate out, the trees, etc. So the volume rendering shows the whole thing. You can adjust the density up and down in order to see different things, but it's a very cruel way to do it.
it's still not as dynamic as it would be if the surgeon were looking with their own naked eyes. For example, many of those images are shown in just shades of gray or white, and there are just too many structures for the doctor to weed through in those images without any distinction. And so it's basically forcing their brains to do this heavy lifting of separating fat from muscle, muscle from vessel, and vessel from tumor. But Dr. Hsu wanted to create something clearer, something that takes away that mental puzzle. This is when the program decided to invest in a process called segmentation. It's where every structure a surgeon might care about is isolated and color-coded. So for example, the tumor is shown in white, arteries are in red, veins in blue, and so on.
And this is much more complicated process than just volume rendering, where you just press a button and then the computer gives you something.
Is it using new technology or is it just more labor-intensive now?
Well, it's not exactly using new technology. It's using a more complex software that we didn't have before. So most places don't use this kind of software because since it is very expensive in order to do this, and it's also very labor intensive because now you need a diagnostic radiologist to actually determine what structure is what.
But even with this expensive software and all the hours of labor that go into segmentation, Dr. Hsu still thought they could do better. Because at the end of the day, to look at these images, surgeons were still just sitting at a desk, looking at a screen, playing with a mouse, but it wasn't simulating the actual experience of what they would be going through in the operating room.
Because I play a lot of virtual reality games, I thought, what's so hard about just having a 3D model in a 3D world and then you can just grab it. People do that all the time in the gaming industry, right? So we decided to use a small amount of funding. We bought a VR headset. And then we found a way to load the program that's able to import the model that we created for different patients into the VR headset. Mm-hmm. And the first time, our surgeon, for example, Dr. Picon, when he first looked at it, he was mind blown. Because instead of looking at it on the computer screen, now you have it sort of right in front of you. And not just right in front of you, but you can walk around it and you can look at it from different directions just by walking around it. Furthermore, you have depth perception, because now you can tell what vessel is closer to you and what vessel is further from you. And unlike on a normal computer screen where everything is flat, now because VR headsets is binocular, so you can actually have a better sense of the depth between different structures. And going beyond that, they can also use a hand controller or sometimes using their hand gesture to just grab the model and then just rotate it to different orientation they want right in front of them. And that, I feel, was a much more native way to look at things instead of just looking at things on computer screen and try to turn it here and there using a mouse.
At first, things were going great. The idea was simple. Surgeons would come in before their operating day, put on the VR headset, and walk through the surgery ahead of time. This gave them a chance to see everything in 3D and plan their moves, almost like a tech rehearsal. But this was back in 2019. And when COVID hit, suddenly no one had any interest in sharing a headset. And if they were to be very honest, the VR headsets were always pretty bulky and clunky, not nearly as efficient as Dr. Hsu had hoped for. So the VR headset plan started to lose traction, and Dr. Hsu was back looking for a better way to do things.
What if we can just create an actual physical model that you can hold in your hand? So instead of holding it with your virtual hand, looking in a virtual environment, what if you can actually feel and also touch the things that you're actually holding? You can touch how big the tumor is. You can touch where the vessel is, in relation to the tumor. How far is it from the tumor? Is it behind the tumor? And I feel the way to do that is to actually 3D print it. So we bought some 3D printers and basically created a dedicated 3D printing lab for our department. And after that, we're able to actually print models and actually give it to the surgeon. So now the surgeon have the models in the hand before and also during surgery in order to plan the surgery better.
And from beginning to end, how long does this process take?
Printing is just not like what people think, that you print something and it just comes out perfectly. You have to print it, then you have to post-process it, and you have to post-process some more, and sometimes mistakes happen, something breaks, and you have to print it again. So I would say the whole process, the segmenting part takes probably a day or two, just to make sure that everything is done accurately. And now you have the computer file. Not everything is printable because you have to sort of do what we call computer-aided design or CAD. further trim the model and also add different supports, at the base so the tumor is not kind of floating mid-air. So there's something to stand on. So that probably takes another half a day. And then we send it to print in our printer, which usually takes about 24 hours because, our models are usually life size. And also we have very high quality printers that will take some time. And after that, it takes probably at least 2 days to post-process. So overall, if things go well, it takes probably 5 days from start to finish, from the patient scan to the delivery model. But I usually ask surgeon to give us at least 2 weeks in order to account for any time off or any sort of mistakes that happen in between. Because mistakes do happen because we're dealing with very delicate models.
So this is really blowing my mind. But if you'll allow me to just push back, is this something that someone can say, well, it's a nice to have? For surgeons, it's nice to have, but is there any research about success rates in surgeries or what's the actual impact on patients?
So I have to admit, this is a very early technology. It's been around for a while, but it is not reimbursable right now because it hasn't been around as long as, for example, traditional CT scans, right? But there has been a lot of research done by the RSNA, which is a radiology society, the 3D printing interest group. And there are different papers that have shown that, having a 3D printed patient-specific anatomic model that has shown to decrease OR time. And by decreasing OR time, obviously, every minute of OR is costly. So basically, first, it saves money, but then there has also been papers that have shown that it may have created better patient outcome. And I have to believe that any bit of extra info for the surgeon would be helpful. Now we're giving them a 3D depiction of the anatomy instead of just one slice by slice by slice by slice. So I have to believe that, if done accurately, first of all, it's got to be done accurately. A high quality model, to me, logically must give the surgeon more arsenal. I have surgeons that told me that he was surprised by where the vasculature or the blood vessel, the big blood vessel, is in relationship to the tumor. Because from the cross-section, from the CT cross-sections, he thought it shouldn't be there. And he questioned me that, are you sure that's where it is? And I said, well, the scan doesn't lie. And I'm not really doing any manipulation. I'm literally just transforming the cross-sectionals into a 3D model. So the relationship is exactly what the CT scan shows. It's just sometimes, looking at cross-sections, our brain cannot put things together perfectly sometimes, that you think something is a little bit higher than it is, a little bit lower than it is. Maybe sometimes, you thought the vessel is on top of it, but it's actually below it. Or you thought it's only touching it, but actually it's actually wrapping around it. So he was surprised by the anatomy, and then he thought this will change his surgical plan completely. And this is the example that shows that, this does have patient impact. Imagine going to the OR, having thought that you have a game plan because you thought that the tumor is in a certain place or not involved by certain structures, but it actually is completely different, right? So not going in with that knowledge, he can adjust his plan and have a better accurate approach. We know patient's anatomy better than anybody else. So once you have a 3D model of the patient's anatomy, the possibility is truly, it's endless. And then you can use that information, that anatomic information, in order to problem solve different things.
Dr. Hsu told me about a patient who had to have his nose removed because of a tumor. Normally, a surgeon would take a mold of the patient's nose before surgery and hand sculpt a prosthetic afterward. But Dr. Hsu had another idea. Why even take a mold of the nose when the patient's CT scan had every detail down to a fraction of a millimeter? So instead, he used it to build a 3D digital model, mirrored the healthy side of the nose to the side with a tumor in it, and printed a new nose with medical-grade resin. Dr. Vladimir Frias, the maxillofacial prosthodontist who worked on this, then added a layer of flesh-colored silicone on top, and the results looked like the patient's original nose. And that's just one example. Clinicians come to Dr. Hsu all the time with problems they're not sure can be solved, and sometimes they can be. With Roswell's 3D imaging program, it feels like they're just getting started and the possibilities are endless. But Dr. Hsu reminds me that this kind of modeling isn't standard. Very few hospitals have the resources to do this kind of work. But I keep thinking, if they did, if this was the norm 10 years from now, what might be possible?
I believe in 10 years, this will be mostly done by AI. We'll have AI algorithm just give us a virtual model. And now you have a virtual model, so you can do all the things I've said. But the 3D printing technology is also going to much, much better than before. 10 years ago, people cannot imagine having a full color printer inside the hospital, but that's what we have now. But imagine 10 years later, what that will happen. Right now, it takes 24 hours to print a model, but maybe in the future, it's going to take 2 hours. It'll be faster, it'll be more accurate. But I think 10 years from now, 3D printing will not be used to depict this model. It'll be used actually for training and also for surgical guides. But the depiction of the 3D anatomy will be it'll be like Apple Vision Pro, but just like a normal glasses, I think. Or might not even be glasses, it might be some sort of a holographic projection because it'll be completely fast. You don't need any CAD in order to make sure it's printable, so you don't have to worry about small vessels breaking. Even in the OR, I think that in the future, that we'll be projecting actual 3D models onto the patient's native anatomy. So for example, when you cut into the liver, your holographic projection or your mixed reality headset, your glasses will be able to show where the tumor is in the liver while looking at the patient's actual liver. And I think that's going to be what the future of 3D imaging looks like. Instead of looking at cross-section images, we're going to be looking at the patient on a table while looking through it by superimposing the 3D models that we have from medical imaging onto the actual patient. It all sounds like science fiction right now. But I think if you ask people 10 years ago, what we have today, they would not even be able to imagine. And people 10 years ago can imagine what AI, ChatGPT now can do. So I think 10 years, I just think it'll be something we cannot imagine right now.
This conversation is blowing my mind because even what you've been able to do with the technology that only exists right now is really amazing.
Every day I feel that, my job is, besides basically reading scans and diagnosing patient disease, we're doing very novel things that I never ever dreamed of just because of the questions that clinicians have and the resources we have that we're able to accomplish things that I don't think anybody else has ever done before.
Thanks for listening to Smarter Than Cancer, a production of Roswell Park Comprehensive Cancer Center.
The show is written and produced by your hosts, Hajar Eldas and David Hoffman.
Production oversight by Peter Sosha.
Additional logistics and support from Michelle Eisenstein.
Our production partner for this series is Citizen Race Car.
Post-production by Gregory Schweitzer for DCP Entertainment.
Publication and promotion supervised by Candice Chanteloup. If you or your loved one has been diagnosed with cancer and would like to schedule an appointment with Roswell Park, please call 1-800-ROSWELL. That's 1-800-ROSWELL. Or visit us at roswellpark.org.
If you're enjoying this series, we'd love to hear from you. Please reach out and tell us about your cancer story, and let us know what topics you'd like us to cover in future episodes by filling out the form at roswellpark.org/.
And if you know someone else who might find value in what we're doing, please tell them about it. You can listen and subscribe wherever you get your podcasts.